second part of digestive system. In first part we have discussed about alimentary canal, starting from oral cavity, pharynx, esophagus, stomach, small intestine, large intestine. Today we will discuss about salivary glands, parotid gland, submandibular gland, sublingual gland. Then we will talk about peritoneum, mesentery, omentum, and retroperitoneal organs. Then third lecture we will discuss about liver, gallbladder, spleen, and pancreas. So let's start from the very beginning. Parotid gland, you can see over here. Before I really start the parotid gland, submandibular, sublingual gland, the location of the parotid gland is behind the ramus. Okay, then the location of the submandibular gland just behind the body of the mandible. So if you know the parts of the mandible, then you can understand the location of the glands. For example, this is the ramus of the mandible, this is the angle of the mandible, and here we have body of the mandible. Let's discuss about parotid gland. You can see over here. Okay, there is a fact that cranial nerve 7, facial nerve, that crosses the parotid gland but do not innervate any structure of the parotid gland. This is an exception. So parotid gland is the largest gland of all three pairs of salivary glands. We have three types, three pairs of gland, right? Parotid gland, two parotid glands, two submandibular glands, and two sublingual glands. All these three pairs of salivary glands, out of these three pairs, the largest salivary gland is parotid gland, okay? And it is composed of a serous acini. It is, the secretion of this parotid gland is serous. And sublingual gland secretions are mucous secretions. And the location of the parotid gland lies retromandibular fossa plus below to the external, just you can say, below the external acoustic meatus and posterior to the mastoid process. Anterior to the parotid gland we have sternocleidomastoid muscle. It is present posterior to the ramus. Again, retromandibular fossa, below to the external auditory meatus. Anterior to this parotid gland we have muscle called sternocleidomastoid muscle. We have discussed about sternocleidomastoid muscle, right? Starting from sternum clavicle, sternocleido, going toward the mastoid process, sternocleidomastoid. It is present anterior to the parotid gland, and posteriorly it is present posterior to the ramus. So this is all about the location of the parotid gland. Shamas, are you getting it? Yes. Okay. Now we'll discuss about parotid capsule. Parotid capsule, which is covering the parotid gland, is made up of what? Made up of deep cervical facial investing layer. You know, deep cervical fascia, one of the layer of the deep cervical fascia is investing layer. That investing layer of the deep cervical fascia, it surrounds the parotid gland and make a fibrous capsule. That is called parotid capsule. Okay. And after the you can see deep cervical facial investing layer makes a fibrous capsule around the parotid gland. That is called parotid capsule. And if we talk about this shape of the parotid gland, it is a three-sided pyramid in shape. Three-sided pyramid with apex directed downward. Okay, you can see like this. If I can make over here, it is like this. It is three-sided pyramid with the apex downward and base upward. Okay, let's discuss about the apex of the parotid gland. It overlaps posterior belly of the digastric muscles. We have discussed about digastric muscles when we were discussing the triangles of the neck. Yes. There is a muscles present over here, anterior belly and posterior belly, and the triangle present between these two belly is digastric triangle or submandibular triangle. So the apex, it overlaps to the posterior belly of digastric muscle, and base of the parotid gland, it is related to the temporomandibular joint and internal acoustic meatus. After that, if we talk about some structures which are present within the parotid gland, these structures are facial nerve, retromandibular vein, and external carotid artery. After this structure, we talk about the parotid duct, which is also called Stenson's duct. The length of this Stenson duct or parotid duct is 5 cm. Same is true with the submandibular duct, that is called Wharton duct. The length of Wharton or submandibular duct is also 5 cm, and the length of parotid duct or Stenson duct is also 5 cm. And the duct, it crosses the lateral surface of the masseter muscle. We know masseter muscle is the strongest muscle of mastication. So it is all about the location of the parotid duct or a Stenson duct. Plus, this parotid duct can be palpated at the anterior belly of the masseter muscle. You can palpate the this tension duct at the belly of the most, you can say, intense part of the masseter muscle. And then the opening of this tension duct or parotid duct. So now we have a parotid gland, and obviously it is a salivary gland. It will produce saliva. So the saliva will be produced within the parotid gland and excreted through a duct called tension duct. And if we talk about the opening of this tension duct or parotid duct, it opens at a second maxillary molar teeth, opposite to the second maxillary molar teeth. We know we have maxillary teeth, molar teeth, premolar teeth. And for that we discussed about a formula, right? For our milky teeth or deciduous teeth, that are protein number 2102. And for permanent teeth, that are 32 in number. The formula is 2123. 2 incisor, 1 canine, 2 premolar, and 3 molars. This is the half of the maxilla or half of the mandible formula.
Yes.
Okay, after this duct, let's discuss about some clinical features related with the parotid gland. First of all, most common tumor of the parotid gland is pleomorphic adenoma. Okay, the second one is, if we talk about the swelling of the parotid gland, most common cause, or you can say most common infection which will cause the swelling of the parotid gland, that is mumps. Most common, yes. Mumps. We have discussed about mumps.
Yes.
What we call in Urdu? Kanpede. Mumps. It is the most common cause of infection of the parotid gland, which leads to the swelling of the parotid gland, and there will be pain. Obviously, and pain will exaggerate at male. When you take the male, then pain will increase in intensity. It is called pain exaggeration over male. And pain on the capsule of the parotid gland due to stretching of the capsule of the parotid gland, plus there is a great auricular nerve stimulation. How the pain develops? First of all, when we eat, there will be stretching at the parotid capsule. As we know, the parotid capsule is made by the deep cervical fascia investing layer. So when you eat something, there will be stretchiness at that parotid capsule that will lead to the pain. Plus there will be stimulation of great auricular nerve that will also cause pain. We are talking about parotid swelling. Most common cause is mumps. And we talk about the complication of the mumps. There are two major complications of the mumps, that are orchitis and pancreatitis. Please don't forget, these two complications are very important as far as your exams are concerned. Okay, then thirdly, we have another clinical feature called Fries syndrome or auriculotemporal nerve syndrome, in which there is a penetrating trauma or an injury to the parotid gland, which will lead to the damage of the, okay, I can do like this. Again, Fries syndrome or auriculotemporal nerve syndrome, that syndrome starts due to the penetrating trauma to the parotid gland, which will lead to the damage or injury to the auriculotemporal nerve or greater auricular nerve. And during regeneration, there are some changing will be there, and it will lead to two complications of the patient. While eating, there will be ipsilateral swelling, pain, hotness, and ipsilateral perspiration on eating. What is perspiration? Sweating. And then on shaving of that sad person, while shaving, there will be hyperesthesia, increased sensitivity at that ipsilateral side. That is called Fries syndrome or auriculotemporal nerve syndrome. Then after there is another kind of clinical feature called parotid abscess. If there is a formation of abscess, what is abscess? Pus. What we call in Urdu? Pus? Resha. If there is a parotid pus, not parotid pus, parotid abscess more specifically, it will spread in our oral cavity also. In order to remove that parotid pus, you need to do an incision 4 cm below the angle of mandible. That is called Hilton's incision. And if you don't know the osteology, how you can understand the angle of the mandible? Again, it is worth repeating that this is the angle of mandible. It is present between the body and ramus of mandible, and that is very obtuse by birth. It is almost 140 degree by birth, and in adults the mandibular angle becomes 110 degree. So just below 4 cm below incision, horizontal incision for the removal of the parotid abscess, and that specifically is called Hilton's incision. You can see over here, parotid abscess, Hilton's incision. Okay, let's discuss. Thank you so much. Let's discuss about submandibular gland. This is the second salivary gland, and it is you can see it is present just anterior part of the digastric triangle. Again, anterior part of digastric triangle. That is why that triangle is also called submandibular triangle. And the gland which is present within that triangle are submandibular glands. That are salivary glands. Second gland we are talking about. It is a walnut size and shape. Walnut is akhroot size and weight, and almost the weight of 20 grams, not 40 grams, 20 grams. And it is a mixed type of gland. It secretes mucus secretion and serous secretion also, but more predominantly the secretions are serous secretions. Okay, and it is a J-shaped gland. J-shaped gland. If I ask from Dr. Aisha, tell me the J-shaped organ. Stomach. If we talk about the shape of the stomach, there are two types of shapes: horizontal and vertical position. If the stomach is at vertical position, as I told you, vertical position happens in long, thin persons, and in vertical position, the shape of the stomach is J-shape. Capital alphabets.
Yes.
And if the person is very broad and very active, then the stomach lying at the horizontal position, and the shape of the stomach is steer horn shape. Steer horn shape. I forgot it at that time. Steer horn. If you can zoom in, steer horn shape. This is the shape of the stomach lying horizontally in broad and highly active persons. Let's discuss about submandibular gland. It is a J-shaped organ, so not an organ, it's a gland, with a large superficial part of mylohyoid muscle and smaller, deeper part. If we talk about the superficial part, there are three surfaces of the superficial part that is superficial to the mylohyoid muscle. We have discussed about mylohyoid muscle already. That is the suprahyoid muscle. Required for the elevation of the hyoid bone. And if we talk about the first surface, that is called lateral superficial surface of the parotid gland, the content present in the this lateral surface are facial artery and is related to the submandibular fossa. Then we have second surface of the superficial part, that is inferior surface, content present in the inferior surface, facial vein and cervical branch of the cranial nerve number 7, that is facial nerve, and marginal mandibular branch of the cranial nerve 7. Cranial nerve 7 have many branches. Two branches, cervical branch and marginal mandibular branch, are present in the inferior surface, that is the superficial part of the parotid gland. Again, cervical nerve basically having 5, you can say, divisions majorly. One is cervical branch of the facial nerve, that is cranial nerve number 7. Then we have marginal mandibular, then maxillary, then zygomatic, then temporal, then facial. These are few branches. So cervical branch and marginal mandibular branch of the facial nerve are present at the inferior surface, inferior part of the superficial part. Are you with me?
Yes.
Let's discuss about the medial and the last part of the superficial surfaces, that is present against mylohyoid muscle, and middle part of the medial surface are related to the hypoglossal muscle and hypoglossal nerve, styloglossal muscle and lingual nerve. Now we'll talk about deep part of the parotid gland. Deep part is present below the lingual nerve and above the hypoglossal nerve. Just think, this thing you should not forget. For deep part is present below the lingual and above the hypoglossal nerve. Now we have discussed about the parotid duct. Let's discuss about the submandibular duct. Submandibular duct or Wharton's duct. Length is 5 cm. Same is true with regard to the Stenson's duct or parotid gland duct. And it opens its secretion to the floor of the mouth, just lateral to the frenulum. We have discussed about the frenulum. It is a fold of mucous membrane required to anchor the tongue in the mouth and help for the swallowing, chewing, speaking. So lateral side of this frenulum we have opening for the submandibular duct or Wharton's duct. The length of the ducts are 5 cm, and the lingual nerve crosses that duct. Please don't forget this thing. If we talk about the clinical features related to the submandibular gland, clinical feature first of all is salivary caliculi. Stone formation. We have caliculi in our kidney, renal stones, renal caliculi. Then we have stones in our gallbladder. gallbladder stones. We can have stones in our salivary glands also, and 80% of these stones are present in our submandibular gland. Okay, 80% of secretions, or not secretions, stones are present in submandibular gland because of the viscous secretion of the submandibular gland. Okay, and there is no fun in telling that if there is any surgery, it will lead to the damage to the nerves. Nerve damage on surgery. How many nerves can be damaged during the surgery? First one is marginal mandibular branch. Marginal mandibular branch obviously is a branch of facial nerve, seventh cranial nerve, lingual nerve, hypoglossal nerve, and mylohyoid nerve. We talk about the marginal mandibular branch damage during the surgery. How this nerve damage if we do a incision below the angle of mandible. And then we have lingual nerve that is damaged. As we know, the lingual nerve passes through the inferior to the third molar teeth. Third molar teeth, okay? Inferior to the third molar teeth. And during extraction of the teeth or during giving the local anesthesia, you may damage the lingual nerve. And after this submandibular gland, let's discuss about sublingual gland. This is the smallest gland of all the three pairs of the salivary glands. And this is the shape of the salivary gland, sublingual. Now we're talking about sublingual gland. Shape is almond shape. Almond in Urdu? Badam shape. And if we discuss about its secretions, this is predominantly mucus secretion, and rest of the glands, submandibular or parotid gland secretions are serous and viscous. Serous for the parotid and viscous for the submandibular gland. And then if we talk about sublingual gland, secretions are mucoid or mucus secretion. It lies between the mylohyoid and side of the tongue. Side of the tongue and mylohyoid muscle. Okay, mylohyoid muscle and side of the tongue. If I can show you over here, parotid gland is present just behind the ramus. This is the ramus, right? And then submandibular gland present behind the body. Sublingual gland present between side of the tongue, left and right, side of the tongue and mylohyoid muscle. Okay, this is the location of the sublingual gland. Are you with me?
Yes, sir.
Okay. There are 15 or more ducts which opens into the submandibular duct only, and half of the ducts that are also called duct of Ravinus that repeatedly, or you can say separately, pour its secretion to the sublingual gland only. So submandibular glands have 50% secretions entering in the submandibular duct and 50% secretion to the sublingual ducts only. And if we talk about the most common damaged artery during the removal of submandibular gland, that are the facial artery, and most common nerve that damaged during the removal of the submandibular gland, that is lingual nerve. And if we talk about the clinical features related to the sublingual gland, ranula, a large mucus retention cyst in the floor of the mouth arising from the sublingual salivary gland. Let's discuss about peritoneum now. It is also today's discussion topic. Peritoneum. What is peritoneum? It is a serous membrane covered by mesothelial cells. Very important structure. Peritoneum. In male, it is a closed sac, but in female, it is not closed because it has three types of openings anteriorly. One for the uterine tube, second for the uterus, and third for the vagina. But there is exception. Exceptions are always there. For male, it is a closed sac. Please don't forget this concept. So you can see over here in females, it communicates external through the uterine tube, uterus, and vagina, and male that are closed cavity. And the serous membrane lined by the mesothelial cells. And there are two types of peritoneum: parietal peritoneum and visceral peritoneum. Parietal mean outer, visceral mean inner. So parietal peritoneum, it lines the abdomen, pelvic wall, okay, and it is a pain sensitive, innervated by the somatic nerves, specifically T7 to L1. That is a pain sensitive. That is a a kind of differential diagnosis between visceral and parietal peritoneum. Parietal peritoneum is pain sensitive, and visceral peritoneum is pain insensitive unless there are some exceptions. So if we talk about serous peritoneum, it covers the viscera, and it is innervated by the visceral nerves that are insensitive to pain, but exceptions. Pain can be stimulated due to the stretchness and distended small intestine or the viscera, or there is ischemia. Ischemia, distension, and stretchness can lead to the pain stimulation in the visceral peritoneum. Otherwise, pain, the visceral peritoneum is insensitive to pain. So let's discuss about peritoneal folds now. First of all, we'll talk about the omentum, then we will talk about the mesentery. We talk about the omentum. This is the fold of the peritoneum extending from stomach to the adjacent organs. And we have two omentums, greater omentum and lesser omentum. Greater omentum made up of 4 layers of peritoneum, but lesser omentum made up of 2 layers of peritoneum. So greater omentum made up of 4 layers of peritoneum, and it consists of following ligaments: gastrosplenic ligament or gastrolenal ligament. You can see over here. Gastro means stomach. Splenic means spleen. Another name for spleen is lenal. Okay, just if you can zoom in, this is the general basic diagram of the stomach. We have fundus over here. This is the cardiac part. This is the pyloric part. We have three layers of the stomach: longitudinal layer, circular layer, and oblique layer. These are the gastric secretions that are coming from the gastric pit. Then we have gastric rugae, also the folds, which are increasing the surface area of the stomach, specifically present in the empty stomach. Now, if I can remove these things, if I can show you these ligaments present are part of the greater omentum. First of all is gastrosplenic or gastrolenal ligament. There is no pun in telling we have a spleen over here. Okay, the ligament called gastrosplenic ligament will start from the greater curvature of these. Greater curvature, we have greater curvature and lesser curvature. So from the greater curvature, this ligament will start and go to the hilum of the spleen. This is the hilum. This curved part is called hilum. So this ligament is called gastrosplenic or gastrolenal ligament. The content, if you want to learn, these are the short gastric artery and left gastroepiploic arteries. Then secondly, we have splenorenal ligament or linorenal. As I told you, spleen or renal are the same things, just like in India, Hindustan or Bharat. So splenorenal or linorenal ligament starts from the hilum of the spleen and going towards the kidney. Which kidney? Right or left? Obviously left kidney. That is called splenorenal or linorenal ligament, and contents are splenic arteries and vessels. Then third one, we have gastrophrenic ligament. Gastrophrenic means, you will tell me, it will start from where? Stomach. Obviously the upper margin of the greater curvature and going where? Phrenic means diaphragm. Going to the diaphragm. That is called gastrophrenic ligament. Last but not the least, we have gastrocolic ligament. So it will start from where? Stomach. Lower part of the greater curvature and going to the colon. Which colon? Transverse colon. This is transverse colon, right? Yes. Like this. So this is gastrocolic ligament. So these 4 ligaments are the parts of greater omentum. And if we talk about lesser omentum, this is a double layer of peritoneum. Greater omentum was 4 layers of peritoneum. That is the dual layer of peritoneum. It extends from the porta hepatis of the liver to the lesser curvature. And if we talk about its ligaments, we have hepatogastric ligament and hepatoduodenal ligament. There should be no problem as far as these locations are concerned. Hepatogastric means you start from the porta hepatis to the stomach. Hepatogastric. Then we have hepatoduodenal, liver to the duodenum and the lesser curvature also. And we have few types, mesentery. Okay, let's discuss about now mesentery also. Before I really start mesentery, omentum is hang down like an apron from the greater curvature of the stomach, and it is also called policeman of the abdomen. Why policeman? Because it helps to prevent the infection. That is why it is also called policeman of the stomach. And then it is also called storehouse of the fat. And it is having a milky spots in that omentum. That milky spots are made up of macrophages. Now let's discuss about the mesentery. That is the largest peritoneal fold attached, and we have the largest fold of the attached with the large intestine and small intestine also. So the large intestine is called mesocolon and the small intestine is called mesentery proper. Mesentery proper to the small intestine and mesocolon to the large intestine. If we talk about the mesentery of the small intestine, that is the broad fan-shaped peritoneum which suspends coil of small intestine, specifically jejunum and ileum. and from the posterior abdominal wall. So this is just a kind of, you can say, broad fan shaped peritoneum attaching the coil of the small intestine, jejunum and ileum with the posterior abdominal wall. Then we have, okay, width of the peritoneum is average is 15 centimeter or 6 feet. And there are two borders of the mesentery: root, that is the fixed border, and intestinal, that is the free border. Let's discuss about these borders. Root of the mesentery, free or intestinal border, transverse colon, sigmoid colon, mesocolon. So root starts from the duodenojejunal flexure going to the right iliac fossa, specifically right sacroiliac joint. And then we have free intestinal border. Then we have transverse colon attaching with the transverse colon, posterior wall of the transverse colon. We have three types of colon, right? Basically, ascending colon, transverse colon, and descending colon. We have sigmoid colon also. Yes. If we talk about the transverse colon or transverse mesentery, from the posterior wall of the transverse colon, that mesentery will start and attach with the posterior abdominal wall. Then we have sigmoid mesocolon, from the sigmoid colon to the pelvic wall. Then we have mesopandex, start from the appendix and attaching with the iliac mesentery. Then after these mesentery, let's discuss about some peritoneal ligaments. Basically what the ligament do, they attaches the visceral solid organ with the abdominal wall. First peritoneal ligament that we will discuss now, that is phrenico-colic ligament. Who will tell me the location, origin, insertion of this ligament? Phrenico-colic ligament. Obviously it starts from the colon and to the phrenic, that is diaphragm. So specifically it starts from this part, splenic flexure or left splenic flexure of the colon and going towards the diaphragm. Then we have falciform ligament. Falciform ligament starts from the liver and it separates the liver from the diaphragm and from the viscera also. And it is also known as round ligament of the liver. Then we have coronary ligament. It covers the bare area of the liver. Then last but not the least, we have ligament of venosum. That is a remnant of a ductus venosus in fetus. Let's discuss about peritoneal cavity at the end. We will not make it boring lecture. Peritoneal cavity is a space present between parietal and visceral layer of peritoneum. As I told you, we have two layers: parietal peritoneum and visceral peritoneum. Parietal peritoneum, visceral peritoneum. In between the parietal and visceral peritoneum, we have a cavity called peritoneal cavity, and there is a fluid also present over here which is required to give protection to the viscera also. What is viscera? Internal organs. Internal organs also called viscera. And we have two types of sac: lesser sac and greater sac. Lesser sac is also called omenta bursa. It is also called left subhepatic space, and it is also called posterior intraperitoneal space. It is a closed sac except it is having communication. And let's discuss about lesser sac and greater sac. Lesser and greater sac having communication with each other with a foramen called epiploic or omental foramen. So this is what is also called posterior intraperitoneal space. It's a closed sac except it is have a communication with the greater sac with epiploic or omental foramen. Okay, and we talk about this lesser sac only. It is the largest port, not just sac. It is having three recesses: superior recess, inferior recess, and splenic recess. And gas epiploic or omental foramen is the opening between lesser and greater sac. Okay, it is. So we were discussing lesser sac and greater sac. Lesser sac is a closed sac, except it is having communication with the greater sac with the help of foramen called foramen winslow, or epiploic foramen, or omental foramen. Okay, let's discuss about omental foramen while we are talking epiploic foramen. If I can show you, it is a connection between lesser sac and greater sac. Let's discuss. This is the lesser sac. Is a foramen over here, and then we have greater sac. Superior part of this foramen, that is a communication between lesser sac and greater sac. Superior part is made up of caudate lobe of the liver. Inferior part is made by first part of the duodenum, and you can say the anterior part is made by the lesser omentum, and posterior part made by the suprarenal gland, obviously the right suprarenal gland, and the inferior vena cava. Most important structure as far as surgery is concerned. Let's discuss about the greater sac. It is divided into three parts by the line of attachment of the transverse mesocolon. These three parts are supracolic part, infracolic part, and pelvic part. And supracolic part present above the transverse mesocolon, infracolic part present below the transverse colon, and pelvic part present below the pelvic bone. Let's discuss, okay, if we really talk about retroperitoneal organs, we have discussed about a ligament called over here. We have a ligament, two types of ligament, hepatogastric, hepatoduodenal ligament. There are few contents. Hepatogastric ligament having content of gastric vessels, but hepatoduodenal ligament having most important contents, common bile duct and hepatic duct, that are passing through the calot's triangle. Anybody knows what is calot triangle? If I can show you over here, here we have a beautiful organ. What is the name of this organ? Liver. We have left hepatic duct and right hepatic duct. This is the common hepatic duct. Okay, and then we have a gland present over here. Who knows this gland?
GB.
Gallbladder. And this is what? Cystic duct. Okay, and there is a triangle present over here like this. The roof of this triangle is made by the inferior border of the liver. Medial border of this triangle is made by the common hepatic duct, and floor or base is made by the cystic duct. That is called calot's triangle. Very important surgically also. Let's discuss about our last topic, that is retroperitoneal organs. There are many organs that are covered fully by the peritoneum, and few organs they are not covered by peritoneum, called extraperitoneum. There are few organs which are covered by the peritoneum in one-sidedly, that are very important clinically and examination point of view, that are called retroperitoneal organs. The organs which are covered by the peritoneum at one side only. In order to remember the organs which are being covered by the peritoneum one-sidedly, that is sad puckers. Sad pucker. S for suprarenal gland, that is the retroperitoneal organs. A for aorta or inferior vena cava branches, retroperitoneal. D for duodenum, except the first 2 centimeters of the duodenum. P for pancreas, except the tail. U for ureter, C for colon, that is ascending and descending colon, K for kidney, E for esophagus, and R for rectum. Specifically, upper second 2/3 of the rectum is a retroperitoneal organs, and lower 1/3 of the rectum are extraperitoneal organs. So that was about our today's class. That is the second part of the digestive system. In this lecture, you must not forget about the peritoneum, mesentery, omentum, sac, retroperitoneal organ, then obviously our 3 pairs of salivary glands: parotid glands, sublingual glands, and submandibular glands. Is there any question?
No, sir.
Thank you so much.